Good afternoon, everybody, and welcome to our third Midlands Population Health Management Academy webinar. My name's Lucy Hawkins, and I'm Programme Manager for the Midlands Support Programme. And today I have with me Al Mulley, who's going to be talking about making visible processes or preferences to deliver what is valued. Before we start, just a few bits of housekeeping. We're going to be recording all the webinars we're running this summer, including this one, and sharing them via the Midlands PHM Academy website. I'll share the link to that in the chat box shortly. We're running till about 4 o'clock. If you have any questions, please do post them in the chat box, and then there'll be some time at the end for discussion. While I was talking, we'll be muting all microphones to minimise the noise disturbance. But if you'd like to ask a question, then just put it in the chat box if you'd like to ask it verbally, and then we'll come to you once we pick that up. This webinar is part of a wider programme of support to accelerate population health management in the Midlands. If you're not in the Midlands, you're very welcome to join us today, but just that's the context for the session that we're running. And without further ado, I will hand over to Al.
Thank you very much, Lucy. Good afternoon to you, Lucy, and to everyone who has joined in. I appreciate your taking the time. Just a little bit of background to give you a sense for why the title, Population Health Management, Learning from Variation to Deliver What's Valued, Making Visible Processes or Preferences. Back on July 2nd, we had the first introductory session of the Population Health Management Program in the Midlands that Lucy just referenced. There were teams from 8 of the STPs, 8 of the 11 STPs in the region in attendance. And 4 of us were asked to do essentially a round-robin exercise. And teams would go from one to the next room, 4 rooms. I was joined by Robin Miller, Mohammed, Mira Gray, and the 4 of us each had 15 minutes to try and engage people, to whet people's appetite, if you will. And our intention was to leave them with an appetite as well. And I thought I would use this opportunity to unpack some of the material. My guess is that many of you, most of you who are tuning in now, were not there in the room. So I'm not going to assume that you have any sense of what's coming, and we'll start from the beginning. Those of you who were in the room, I hope you can join in with the chat and with audio. To give a sense for whether or not this is helpful and whether it raises questions that you would like addressed. Lucy suggested that microphones be kept on mute while we're going through the slides, but I would like to make this as interactive as possible. If you have a question that you think would be better asked before we get through the slides, indicate that with a chat message. I'm here with my partner from Dartmouth, Margaret Mulley, who is going to be working with Lucy to help me manage the chat in real time. And if you have a question that you'd like to be answered, just let us know and we'll go ahead and do that. Otherwise, I'm going to pause twice during the course of the slides and ask some questions. And the questions are designed for people who have a reference population in mind. All of the teams, the 8 teams from the Midlands STPs, have a reference population in mind. And what we mean by that will be recognized by those of you who were listening to Meyer about 8 or 10 days ago, when he talked about having a population identified where you really would like to focus because there might be some particular challenges. Maybe it's a population of people with multiple long-term conditions. Maybe it's the frail elderly, maybe it's people with mental health problems, people nearing the end of life. So those of you who want to be thinking about what we learn together in the coming hour in the way that the 8 teams and the STPs from the STPs are, you might right now choose a population that you have a particular interest in among those or others to have in mind as we go through this. Okay, I'm going to begin with the slides now. Just not to distract myself, I'm going to turn my video off. You can do the same or leave it on. Here are 8 questions, and let me assure you that we are not going to try and answer these 8 questions. Remember, I said the goal is to unpack a little bit of what we did back on July 2nd, but also to leave you with an appetite for more. On July 2nd, I asked 2 questions. How do we learn from variation in outcomes and costs to improve delivery of health and care services? And how do we learn from variation in what services are actually delivered to seemingly similar people to improve personal and population value? Those are the questions that we're going to focus on. But I'd also like to dig in a little deeper to the question, why do people in similar situations and considering similar options sometimes make very different choices? And if people do make different choices under seemingly similar conditions, what distinguishes a good decision from a bad decision? Largely, we're going to stop there in this hour, but I want to give you a sense for how this way of thinking about learning from variation is extended. And you can see that in the questions 5 through 8. How can we measure decision quality across conditions and contexts? Why should improvement in decision quality be the strategic intent of ICSs, or at least one of several foremost strategic intents? What kind of leadership is needed to achieve measurable improvement in decision quality across integrated care systems? What are the roles and accountabilities of citizens, patients, clinicians, commissioners, policymakers in decision quality improvement? And of course, we're talking about cross-sectoral integration of care. So we're talking about those who work with the local authority in social care and in other ways, public health doctors, etc. So here are the 4 questions that we're going to focus on today. And just to get your fingers going with the chatting, and let us know if you want to say something out loud. Let's start with this 4th question. How do you distinguish a good decision from a bad decision when it's made in the face of uncertainty?
Jeremy says, by its consequences.
By its consequences. Actually, yes, you can judge the quality of a decision by its consequences. But I did try to stress the fact that I was talking about decisions made in the face of uncertainty. And if you think about it, you really can't judge the quality of a decision made under circumstances of uncertainty by its outcome. So if that's what you meant by consequences, we may disagree a bit. If you think about a surgical intervention with a very low mortality rate, deaths do happen, regardless of how good the technique is, regardless of, we are just not in control of situations. When I'm teaching undergraduates, I sometimes talk about getting soaked in a drenching rain on the way home in the afternoon, having not brought my brolly with me. Is that a bad decision? Well, it depends a good bit on whether or not I check the weather forecast. If I did check the weather forecast and there was a 70% chance of rain, it probably was a bad decision. If I checked the weather forecast and there was virtually a 0% of rain forecast, maybe it was a good decision. If it wasn't a good decision, the implication is I would carry my brolly with me every day. So it's really important, I think, in healthcare for people to understand that you have to find other ways to measure the quality of a decision. We'll talk a little bit later about economic decision theory and expected value decision theory, and how thinking about the probabilities of outcomes is an essential way to start to make a good decision. But that only gives us half the story. We also have to think about the consequences of those decisions, Jeremy, and what they mean to the person who lives with them or the people who live with them. Am I wearing my old clothes when I get caught in that drenching rain, or am I wearing a brand new suit? So let's move on at this point. How do we learn from variation in outcomes and costs to improve delivery of health and care services? I wasn't online with Mohammed last week when he did a session following up on his round robin on July 2nd. But I did have a chance to look at his slides quickly, and some of this is clearly related, but it's a good bit more simple. And it's simple because what I'm hoping is that the clinicians and the social workers and the public health people and the commissioners and the analysts who are listening can think about some very simple ways of communicating among each other about what the learning opportunities are by looking at variation in outcomes and costs. I'm going to begin with a quick historical perspective on my understanding of learning from variation in outcomes and costs. Practice variation was discovered or rediscovered by Jack Wenberg in 1973. His first clinical publications began in the early 1980s, 1982, in a paper that was authored by a UK colleague of ours, Clem McPherson as first author, and Jack as one of the other four. And what Jack had done is he went to Vermont from Johns Hopkins, having been influenced by Kara White's Ecology of Medical Care, which some of you may know of, in order to study the ecology of medical care in Vermont. But he referred to it as the epidemiology of healthcare. He hoped to be sure that people in the northern part of the state, which was rural and quite poor, had enough resources, had enough doctors, had enough hospitals in order to sustain their health and well-being. Well, what he found was that the people in the poor rural sections did just fine, even though they didn't have as many capital resources available for their health care. But there was dramatic variation in the rates of surgical interventions like tonsillectomy, which had been described by Glover in 1938 in the UK, but also hysterectomy, prostatectomy, back surgery, etc. The paper that I just referenced, 1982 in the New England Journal, demonstrated that that wasn't a problem unique to New England and the United States. The same variation was true in the Midlands of England, studied by Clem, and in Norway, studied by Eric Hovind. And the variation seemed to be a property of the clinical condition and the level of science that supported decision-making. There were very few randomized trials available for any of these interventions, and as a result, there was a great deal of discretion. Jack took the same methods that he used to study the epidemiology of healthcare in New England that were used in England by Clem and in Norway as well, and extended them across the United States. What he did was he took the hospitals that were capable of doing really advanced surgery and neurosurgery and cardiac surgery and looked at the flow of patients to those hospitals. And he called the geographies from which those patients flowed hospital referral regions. And there are 306 of them in the United States. He then looked at variation in inputs, rates, and outcomes of diagnostic, medical, and surgical interventions. As I'm sure many of you know, Muir Gray and colleagues replicated that work and published the first NHS Atlas of Healthcare in 2010. Again, looking at inputs, rates, outcomes, diagnostic, medical, and surgical interventions. Getting back to the question, how do we learn from variation in outcomes and costs by making visible underlying preferences? I joined Jack in 1982 in doing this work. And at the time, we recognized that there was substantial variation in operative mortality rates following surgery for stable angina. In fact, the rates varied from just over 2% to just under 6% in the 5 hospitals that did that procedure in northern New England. What we did is we enlisted the chief of cardiac surgery at Dartmouth and worked with him to engage the chiefs of surgery, cardiac surgery in the other 4 hospitals. And together we hired an engineer. The engineer's name was Joe Casper. And we basically hired Joe to follow patients through the intake and the diagnostic process and everything that it took to produce that coronary artery bypass operation. And over a relatively short period of time, the overall mortality rate among the hospitals fell by 40%, and the distribution narrowed quite significantly. Later, in 1996, when the first atlas was published, the 30-day mortality rate varied from more than 10% to just about 2%. And you can see in replicating the kind of work that was done in the early 80s, there was a remarkable amount of work in the United States replicating that and reducing rates elsewhere. Now, I want to distinguish that. That's variation in outcome when the same intervention is used for seemingly similar patients. We're going to contrast that with variation in per capita rates, which reflect variation in choices made by or for seemingly similar populations in seemingly similar patients and populations in the same 306 hospital referral regions. We'll come back to that as we address the second question. But let me just give you a couple of examples of other ways of learning from variation in outcomes and costs by making visible underlying processes. This is John Burke Meyer, a colleague who was at Dartmouth for much of the time that I was working with Jack. In 2003, many of you may know the paper he published demonstrating that hospital volume was significantly associated with outcomes for surgery. More recently, he did a study in 2010 published in the New England Journal that essentially made visible the operative technique of about 30 bariatric surgeons doing bariatric surgery for obesity in Michigan. And he initially thought that he would have to develop a very complex system to quantify the surgical technique, the surgical skill of the surgeon. It turned out that when these surgeons submitted a video of their bariatric operation, they were all asked to submit an example of their very best technique. And yet on the one hand, at the high end of the technique scale, you had people who looked like they were Swiss clockmakers at the end of the instruments doing this laparoscopic surgery. On the other end, it looked anything but that. So it didn't take a great deal of time and energy to develop a measure for surgical skill review. And there was a rather dramatic distribution of surgical skill rating and a very strong relationship between the complication rates, which were as high as 20 all the way down to well less than 5, and you can see the association. This is really a very memorable way of thinking about making visible underlying processes in order to learn from variation, in this case outcomes, and also costs. Now, this brings me back to the late 1980s. Brent James, who was responsible for a lot of the genius of Intermountain Healthcare's quality improvement efforts, had recognized that we were studying practice variation for benign uterine conditions with transurethral resection of the prostate. He was much more interested in improvement science, which is what we call it now, and was wondering about the surgical technique of surgeons at Intermountain. And what you see here is grams of tissue per surgical minute with different urologists performing the operations. You can see over on the far left, urologist M gets about 1 gram of tissue out per minute. Over from that, urologist J, urologist J, I won't try to go back, I can go back. Urologist J takes about twice as long. Go all the way over to urologist F, he takes 4 times as long, maybe 5. Now, there was a relationship, I won't go into the details here, but there was a clear relationship between evidence surgical skill and average hospital cost. Again, making visible underlying processes. What that led to was a very interesting demonstration of how to develop learning processes with feedback loops. Alan Morris was working with Brent James, and he knew about the work that he had done in urology and other surgical techniques, including the example that Muhammad used, colorectal surgery. And what he was asked to do was to be the regional principal investigator for a randomized trial of the artificial lung versus standard ventilator therapy. Now, he worked in the intensive treatment unit, wondered what standard ventilator therapy meant, recognized that he and his colleagues didn't have very much evidence. In fact, the evidence was largely rubbish about where the tidal volume should be set, what the respiratory frequency should be. But Brent insisted that they nonetheless create a best practice protocol, even if the evidence was rubbish, for standard management, but that clinicians be encouraged to modify those settings based on the patient's variable needs. And it was this variation in practices adapted to the needs of the individual patients that created an enormously rapid learning process. So much so that within 3 years, the control group patients in this region that had created this feedback loop had survival improved from 9.5% to 44%, nearly 500-fold improvement. While cost per hospitalization fell by 25% and physician management time fell by 50%. Now, what I'd like you to think about and chat with us now is, how is this approach to learning from variation relevant to improving outcomes for a reference population that you have in mind? Are there opportunities to accelerate learning with baseline protocols designed to capture warranted variation with the population that you have in mind, designed into processes? Yes, and feedback, one of the ways to think about what Alan Morris did with Brent was they created a mechanism to say, look, there's a lot of warranted variation based on clinical differences that patients exhibit. And it's a tacit knowledge that we apply often. And sometimes it can be very subjective, maybe not when you're changing the dial on a ventilator, but certainly in other clinical decisions that are being made. And if we can create feedback loops where we capture that tacit knowledge by insisting that everybody follow the guideline developed with the rubbish evidence, solely because we want to learn about the quote-unquote exceptions. Think about this as exception reporting, not to excuse not doing something, but exception reporting solely for the purpose of learning. It becomes very powerful. The reason I underlined warranted is I was the first person to make the distinction between warranted and unwarranted variation in some research related to intensive care unit treatment way back in 1981. And it is enormously puzzling to me how often people talk about reducing unwarranted variation. And you can look in the same paragraph, the same chapter, the same monograph, and not even find the word warranted, the phrase warranted variation. We have so much to learn from warranted variation. How do we learn from variation in what services are delivered to seemingly similar people to improve personal and population value? Well, we talked about hiring Joe Casper to follow people through and take notes about where the anesthesia screen was and how much talk there was among the surgical team in the OR, and other variations in processes of care. And I mentioned that equally important is to understand variation in the rate at which interventions are done within seemingly similar populations. In the first case, the question is, are we doing the right thing? Are we doing things right? In the second case, the question is, are we doing the right things? What we did in the early 1990s, even before the Atlas was done, was develop a series of 9 shared decision-making programs that were highly sophisticated. This is a picture of some of the screenshots from the one that we developed on coronary artery surgery for people with stable angina. The clinician down in the lower right at the time was the president of the American College of Cardiology. So we had a lot of buy-in from scientific leaders. We had assembled the databases, the largest 3 databases on cardiovascular care in the US from Duke, from New York, and from New England. We developed a logistic regression model and Cox hazard models to customize probabilities of outcomes. Most importantly, we gave patients a sense of what the trade-offs were. We helped them understand that there was kind of a misguided belief that bypassing stable plaques in people who had stable angina not only reduced their angina, but dramatically reduced their risk of a heart attack and sudden death, when in fact 85% of those outcomes were caused by vulnerable plaques that were too small to bother to bypass. It was as easy to get patients to understand that with a little bit of animation that I won't show you now, as it was to get clinicians to understand that. And when they did, the results were rather remarkable. Here's the distribution of CABG procedures per 1,000 Medicare enrollees. That means people over age 65, ranging from 3 per 1,000 to 12 per 1,000. Now, at the time, a study done in Canada demonstrated that if you had 1 or 2 vessel disease, that's the 3 bars over on the left side of the graph above the distribution slide. If you had 1 or 2 vessel disease, and therefore were least likely to benefit in terms of a heart attack or sudden death, compared to people who had worse anatomy of their coronary arteries to the right, and you were very old, not very old, but older than 75, meaning you had the greatest likelihood of being harmed by either a stroke or cognitive dysfunction that persisted after your surgery. You were 16.75, I'll round up. You were 17 times as likely to have surgery in the US, Boston or New York, as you were in Toronto, Canada. Now, despite that difference in utilization in Canada, when people engaged in shared decision-making with the program I just described in a randomized trial, the rate of surgery fell 26% there. And if you map the demographics of that population against the US, that would be a rate lower than all of the 306 hospital referral regions in the US. Now, remember, this was done in 1982. The Dartmouth Atlas was published in 1996 and continues to be published to this day. The finding of the Dartmouth Atlas was really threefold variation in per capita costs in different hospital market areas. For instance, threefold variation costs in Miami, threefold higher than in Minneapolis. Leading to this question is, does higher intensity in cost lead to better outcomes? No, it doesn't. Does it lead to better access? No, it doesn't. More difficulty for patients seeing doctors with longer waits. Even the doctors found greater difficulty admitting patients to hospitals and obtaining referrals in the high intensity regions. And both doctors and patients thought that their relationships with each other were poor. The sources of this waste and harm can be thought of as failure to deliver effective care safely, and that's going back to outcome variation. Overuse and underuse of what we refer to as preference-sensitive care, uninformed clinical decisions, like those that are being made for stable angina, when you don't understand the trade-offs and the doctor doesn't understand what matters most to the patient. Maybe the last thing they would want to do is to put their cognitive function at risk, given their avocation and their vocations. And then overuse of supply-sensitive care, which often reflect investments in capacity, the human resource capacity, the capital investment capacity, in capacity to do different interventions. Now, what the NHS Atlas showed is that this isn't a problem of the market, although the market contributes a great deal to that uninformed investment and supplier-induced demand that results. But in the NHS in 2010, there was threefold variation among the 152 PCTs in per capita cost for cancer and heart disease care. There was eightfold variation in stents placed for stable angina after a great deal was invested in increasing capacity to treat stable angina with either surgery or stenting. Going back to learning from variation in outcomes and costs by making visible underlying processes, GIRFT is largely about that. Getting it right the first time, emphasized by the Carter Review and the model hospital. Deep wound infection rates vary eightfold, and one can hire the equivalent of a Joe Casper and have them follow people through and make visible the underlying processes and stop the processes that are associated with bad outcome, increase the processes that are associated with good outcomes. You can also respond to variation in cost by improving procurement management. But there's fourfold variation in the rate at which joints are replaced across the NHS, just as there's fourfold variation in the US. And this is recent data. This is 2016 data for the US, and it ranges there from just over 7 per 1,000 to about 24 per thousand. And you can see over on the right some cities with some particularly notable rates. Salt Lake City, where Intermountain is, 20 per thousand. New York, which is generally a high intensity utilization region, which is only 9 per thousand. Now in 2001, Gillian Hawker in Canada, in Ontario, noticed that there was a twofold variation in joint replacement rates on the western side of Ontario and on the eastern side of Ontario. And she'd read the work that Wenberg and I and others had done, and she wondered if patient preferences could explain this. So what she did is she identified some 250 or so patients who were perfect candidates. Nice guidance would have said, this is the kind of patient in which you do a joint replacement, based on the history, the physical examination, the images, and what seemed important to them. But when you looked at those patients and applied them to the US listing here, if every one of those patients got it, it would be higher, the rate would be higher than all of the US hospital referral regions by quite a bit. If you then took an intentional approach to really engage that patient and understand what matters to them and be sure they understood the trade-offs, be sure they understood that it'd be hard for them to kneel, so if they were a gardener, maybe they didn't want that knee replaced, here's what the rate was. So you can see this dramatic change when one truly engages a patient, informs them about the benefits and the harms, makes sure that they understand the trade-offs, and then makes a decision that is consistent with matters most to them. This is a high school basketball coach. He talks about how only his left knee hurts. He clearly couldn't run up and down the court with his players as much as he wanted to. He mentions the fact that his images, his x-rays, looked identical, even though the right knee barely hurt at all. In quality improvement speak, he would be concerned, he should be concerned about wrong side surgery once he was anesthetized, if they were relying upon an x-ray that had been chosen from the wrong folder. Not wrong patient surgery, wrong side surgery. Here's a patient who chose not to have surgery because she understood the trade-offs. Maybe she did like gardening. Maybe she knew that if she continued to exercise, she could delay a time when the pain would be such that she would really want to have surgery and therefore less likely to need a second operation in the future. This is a Peter Drucker quote: "There is nothing so useless as doing efficiently that which should not be done at all." So we learn from variation in outcomes and costs by making visible underlying variation in processes. A simple way to talk to one another, I suggest, about what we're up to as we try to improve population health management within integrated care systems. We learn from variation in choices and the resulting variation in per capita rates within populations by making visible the underlying variation in preferences. And we're interested in the preferences of those who will live with the consequences of the decision. We want to distinguish that from a local professional conventional wisdom that has a collective preference, or that is in response to a pathway that has either good evidence or bad evidence, but treats every individual as if they feel the same about the risks and the benefits and the harms. So going a little bit deeper here, why do people in similar situations and seemingly considering similar options make different choices? I had the privilege of being the first international visiting fellow at the King's Fund, 2011 and 2012. And what I was asked to do was to join up the evidence and join up the theoretical thinking as well about three things: practice variation, shared decision-making, and commissioning. And what I did was to bring in two colleagues, one who is an expert in innovation and one who is a GP from the UK, Glenn Elwin, who had done a lot of work in shared decision-making. And we chose not to use the term shared decision-making once in this 50 or 60-page monograph. what we decided to do to try and elevate the significance of shared decision-making in the minds of clinicians, commissioners, and policymakers, and citizens as well, was to equate the importance of a preference diagnosis with a disease diagnosis. We began with two fictional cases. Linda, who was diagnosed with breast cancer at age 58. She was devastated by the news. She did not want to have surgery on her breast of either kind. She eventually went ahead with the surgery. She was just beginning to recover physically, but not emotionally, when she got a call from the hospital. And what the person on the end of the phone said to her was, "We're so sorry. We have to tell you that you didn't have breast cancer after all. There was a mix-up in the pathology lab. You were operated upon based on someone else's pathology." She was devastated. Now, move over to Susan. Susan was 78 years old. Susan was less shocked. She had a family history of breast cancer. She had at least one long-term condition. She knew she wasn't going to live forever. She too, though, really regretted the prospect of having to have surgery. When she had it and was just beginning to recover physically but not emotionally, she called a friend to look for some comfort. And they had tea together, and the friend said, "I wish we'd talked about this before you made your choice. I made a similar choice long ago, and learned that I could take hormone therapy to slow down the cancer, to make it less likely that I would die of this disease as opposed to die with it." And Susan knew she would have made the same choice. Our point was the scalpels were equally sharp, the recovery is equally fraught. The only difference was the reaction. In the first case, there was a lawsuit and people lost their jobs. There was a shakeup in the pathology laboratory. In the second case, there was nothing. It was the silent misdiagnosis. Now, in developing measures of decision quality, which we're not going to get to talk about in any depth today, we interviewed about 120 women in the Boston area about their sense of concern when they learned that when they learned that they had the diagnosis. We were able to identify 12 concerns doing qualitative research. We were able to rank those concerns. We then shuffled those concerns and presented them to doctors caring for women in Boston and asked them if one of the top 3 of these 12 concerns was living without a breast. Among the doctors, 71% believed that their patients would put living without a breast as one of the top 3 concerns. Actual patients, 7%. What we then say in this monograph is that in other sectors of the economy, certainly in the commercial sector, there are serious consequences for knowing so little about what the people care about. Let me let you listen to Tina. Tina is a woman that I interviewed in the mid-90s when we were building those shared decision-making programs.
I felt the best thing to do, and the most conservative, smartest thing was just get rid of it. It's bad. Just don't take chances. I knew me. I could not live every day wondering, oh, is there any left?
This is Ruth. You can see I interviewed her at the same place. We were on the back porch of a volunteer, leader of a volunteer organization dealing with breast cancer in the Chicago area. Listen to Ruth.
It's possible to do the conservative surgery, to take out the lump and surrounding tissues, and still be left with a breast. It's very important for a lot of women.
I want to go back to my underlining of the warranted variation. If you think about the kind of quote-unquote exception reporting that led to such rapid learning from variation in processes, when tacit knowledge had to be brought to bear in a clinical situation, think about the analogy here. There could be nothing more subjective than a patient's preference in a situation like this. And in order to really deliver person-centered care and respect them enough to listen and learn their preferences, and then consider what matters to them as we help them make treatment choices. If we really want to do that, we're going to have to get comfortable with that kind of exception reporting around patient preferences. Let me turn now to prostate disease. I'd mentioned that we were focusing on benign prostatic hyperplasia as we developed the model for shared decision-making back in the early 80s. And what we did is we developed a symptom score called the International Prostate Symptom Score. We applied it to more than 500 men who were considering surgery. In fact, they were on the waiting list for surgery at various hospitals. We saw a rather dramatic reduction in those who wanted to have the surgery. We also recognized that there was dramatic variation in how men responded to exactly the same symptom score and to the prospect of complications. Complications that were so frequent, 80% of the time men have a TERP, they have something called retrograde ejaculation. Complications that were so frequent that the urologist didn't even consider them complications. Listen to this man. These two men down here have exactly the same symptom score on the IPSS.
It's annoying. It's bothersome, but it's nothing that I can't live with. I say, as long as I know what's going on, it's going to happen, it probably won't get any better. I just accept it.
Now?
I'm a construction worker, actually. I work on a roof, so there is a problem in terms of the logistics of all this. I'm high in the air, actually. It takes a while to get down to whatever facilities are available. Initially, I'd always be very refreshed when I wake up in the morning. I'm an AM person, and as this has become more and more of a problem for me, I find that I'm not getting refreshed from sleep at all. I'm still virtually as tired when I go to bed at night as when I get up in the morning. So this is very much a factor for me.
So if we were in a room together and I could see you raising your hands, I would ask at this point, should these two men be equally likely to have surgery? And if you're like most people that I've presented this question to, very few raise their hand. Clearly, the man on the left has much more to gain, even though their symptom scores are roughly identical. Now, you then have to think about how these two men would feel about retrograde ejaculation. We discovered back in the 80s that some men are appalled by the idea and some men just aren't bothered by the prospect. When you use this approach to helping inform patients and give them the autonomy to make a decision and the competence to make a decision, men who feel really bothered by their symptoms, like the man on the left, are 7 times more likely to have surgery than men represented by the man on the right. When a man is really bothered by the prospect of retrograde ejaculation, he's 1/5 as likely to have surgery compared to men who are not bothered by that prospect. This just gives you a taste of the potential power of strategically measuring decision quality to assure that we're providing personal value at the level of the individual. Because as Drucker says, there's nothing more inefficient than doing well what should never have been done at all. Now, when you think about the forward view and the goal of a triple integration, primary with acute, mental with physical, health with social care, and then you think about what healthcare, narrowly defined by clinicians and academic healthcare centers, contributes to the health and well-being over the life course. In the figure over on the left, it's just 21% compared to, it's just 11% compared to 9% for environment, 21% for biology, 38% for behavior, and 27% for social determinants. You see that there's an opportunity with cross-sectoral thinking to avoid substituting high-risk and high-cost social care for services in the community that would better meet the needs of those we serve. to avoid substituting high-risk, high-cost healthcare for services in the community that would better meet the needs of those we serve. We heard many stories working with 4 MCPs and 2 PACs, vanguards across the country in 2016 and 17, and many more similar stories working with 6 reform teams in London in 17 and 18. And these stories were about, for instance, old frail women who would say during the difficult re-enablement period, I really didn't need this hip replaced, I just needed my banister repaired. So I could get down the steps to the pavement to talk to the postman when he came so I wouldn't be so lonely. Or people who might have a hip replaced or be put on antidepressants because there wasn't the time to understand that they were grieving, not the loss of a husband or a family member, but the loss of a pet. And their decreased exercise and getting out was misinterpreted. I'm going to close with 2 stories to highlight this point, and then we'll go back to the questions and hopefully interact a bit more. Learning from the most from vulnerable populations is because often they have a sense that their choices have been so constrained by the circumstances that they've been born into, that they're the ones where there's the greatest opportunity to make a difference by engaging them in understanding the trade-offs of what we have to offer, but what we especially have to offer when we're working across sectors, and including social care and public health. The 2 stories I want to close with, Pat Deegan is a woman who worked closely with a colleague of mine and is a colleague of mine at Dartmouth. The colleague is Bob Drake, and Pat tells a story about being diagnosed with schizophrenia when she was 17 years old. She presented with auditory hallucinations. This was very frightening, of course, to her, but to her family, to her friends. She saw a very good psychiatrist practicing at Harvard at the time, who treated her compassionately. And the auditory hallucinations were gone within 6 months. He continued to see her at 3-month intervals and then longer intervals. And 4 years later, at age 21, she summoned up the courage to come back to one of those checkup visits and to say to him, I've been listening really carefully every time I come back to see you. And I've concluded that you think that your job is to keep me from hearing voices. You've done that. I'm grateful. My family's grateful. My friends are grateful. But look at me. I've gained 40 pounds since we've met. I chain smoke. I sit in front of the television all day. I have no motivation to do anything. I think it might be related to how I'm being treated. I've concluded that your job is to keep me functional enough to have a job of my own and let me worry about the voices. There's another story that I sometimes elaborate on more than I'm going to today. It's a story about Archie Cochran, appropriate enough, given that we've been talking about evidence, and he is the namesake for the Cochran collaboration. Archie Cochran was a prisoner at Elsterhorst during World War II. And as a prisoner in the prison camp, he was made responsible to care for the other prisoners, many of whom were English-speaking, British or American. Some were not. And he tells a story about one night when a Russian who did not speak English was brought in, who was clearly in a great deal of pain. And he was afraid that his yelling out was going to keep the ward, keep the camp room open awake all night. So he put him in his room. He continued to cry out in pain. And in his memoir, Cochran says, I had no morphia, just aspirin, and it didn't touch the pain. He says he instinctively went over to the bed and took him in his arms, and the screaming stopped at once. And he died peacefully 2 hours later. Now, I heard that story from Ian Chalmers. I heard it from others, and they all stopped there. But in his memoir, he goes on and said, I learned a great deal about care of the dying. And I'd never told this story because I was so ashamed of my diagnosis. I thought the pain was pleurisy. It was about fear of dying in loneliness. I don't think He should have been ashamed, and I'm not sure he made a misdiagnosis. Would he have made that diagnosis of loneliness and instinctively held him in his arms if he had the morphia? So how is this approach to learning from variation relevant to improving health and well-being for a reference population, for frail elderly, for people near the end of life, for people with mental health problems? I pretty much signaled the answer to this with the last two slides. How important is integration of health and social care, or integration of primary and acute mental and physical health and care to achieve population health impact with improved decision quality? If we have a relatively narrow focus on what is conventionally defined as healthcare, such that we miss the opportunities to replace handrails instead of hips or knees, or if we miss the opportunity to comfort somebody, and perhaps when they're ready to replace the pet, as opposed to medicalize the kind of symptoms and concerns that routinely bring people into GP surgeries. How are we ever going to have a sustainable healthcare system that produces population value as well as personal value? Coming back to the question that we began, what distinguishes good decisions from bad decisions? I think one way of phrasing it would be it's doing your very best to minimize unwarranted variation by working very hard to understand the probabilities of outcomes with different interventions that could be chosen as the clinical response to a medical problem. And to the extent that we don't do that, the variation is termed unwarranted. But a good decision also depends on taking the time to understand what matters to an individual, what trade-offs they're willing and not willing to accept, and to make a decision that is consistent with their preferences. Otherwise, there's a failure to deliver personalized care. And that's the variation that could be considered warranted. Now, there's a longer story about how decision quality has been measured in the past, how the academic approaches might be simplified to put them into action to provide real-time feedback as one develops new models for implementing population health management in primary care settings, for instance, and in other settings. Why should improvement in decision quality be the strategic intent of integrated care systems? How does one lead in order to see this happen with a sense of mutual accountability, or what Muir might refer to as a sense of stewardship, a culture of stewardship across the integrated care system, including patients and citizens? And what are the roles and accountabilities, and how can you define those roles and accountabilities of citizens, patients, clinicians, commissioners, health policymakers in decision quality improvement? In our work with the Vanguards and in London, we referred to this as a form of mutual accountability. Now, for further exploration, coming from Dartmouth in the Population Health Management Academy, you'll see adaptation of a set of design principles and a set of 8 essential capabilities that begin with developing a logic for learning that you can implement by linking the learning for real-time feedback into the front lines of practice, and then learning from variation, both kinds of variation, outcomes and costs, by making visible underlying unwarranted process variation, and in choices people make and the resulting rate differences by making visible underlying preferences to produce personal value as well as population value. For those of you who tuned in and listened, many thanks to you. I'm sure that I'll be seeing some of you in future meetings of the Population Health Management Academy for the Midlands. and perhaps in a future webinar as well. Thank you very much, all.